Good morning, ladies and gentlemen. We'll begin the broadcast momentarily. Good morning and welcome to our September educational call of the Ohio Hospital Association's statewide sepsis initiative. I'm James Giuliano and I serve as Vice President of Quality Programs here at the Ohio Hospital Association. Today's program will address care of the pediatric patient with sepsis that presents to an adult emergency department. We all agree that timing is so critical in recognizing and treating sepsis patients. So what needs to happen when an infant or child requires sepsis care and arrives in an adult hospital? Well, today we will hear from a pediatric hospitalist and intensivist who will expand upon that scenario. Joining us on our call today are members of the OHA HIN, the OHA Statewide Sepsis Initiative, the Ohio Department of Health, the Health Services Advisory Group, the New Jersey Hospital Association, the Hospital and Health System Association of Pennsylvania, and Sepsis Alliance. Our governor, Governor John Kasich, has proclaimed September in Ohio as Sepsis Awareness Month. We always begin our calls by revisiting the goal of this statewide initiative, that being to achieve the OHA's board-directed goal of a 30% reduction in sepsis mortality statewide by the fourth quarter of 2018. Today, we are honored to hear opening remarks from the Ohio Hospital Association President and Chief Executive Officer, Mike Abrams. Mike, thanks so much for joining our webcast today. You know, we all recognize that mortality reduction initiatives such as this one must begin with very solid leadership sponsorship. Can you please comment on the role of hospital leadership in our statewide initiative and why this initiative has been so very crucial?
Well, Jim, in 2015, the association identified sepsis as a quality improvement focus area and set a goal, as you said, to reduce sepsis mortality in Ohio by 30% by 2018. Last year alone, Ohio hospitals treated more than 38,000 patients for severe sepsis or septic shock. We know that sepsis takes the lives of 250,000 people in the United States every year. And sepsis is the most expensive condition to treat in the entire U.S. healthcare system, accounting for $24 billion in annual costs. So we at OHA worked closely with hospital leadership to not only secure their commitment to this effort, but also to assist them in eliminating barriers to early recognition and appropriate treatment. We did this by receiving a formal leadership commitment from every one of our participating hospitals to take both leadership actions as well as operational actions that result in fewer sepsis deaths.
So the commitment to action has certainly been notable. How then would you describe the engagement and the participation from Ohio hospitals?
Well, even before the CDC declared sepsis a medical emergency and emphasized the importance of timing to stop the progression, our initiative focused very specifically on evidence-based practices to achieve a reduction in preventable sepsis mortality. We've seen a high level of engagement. For example, on last month's webcast, we had over 750 attendees participate with pertinent questions raised during the interactive session. But most importantly, we're pleased that we've estimated greater than 2,000 lives have been saved since the inception of the initiative.
Mike, thank you for your perspectives and your leadership, and most importantly, thank you for joining us today on our call.
Thank you.
Next, I am pleased to welcome back Tom Heyman, President and Executive Director of Sepsis Alliance, for remarks as well. Tom, I'll turn it over to you now.
Thank you, Jim, and thank you, Mike, for the commitment from OHA. It's really tremendous what you guys have achieved and what you're looking to achieve going forward. I really appreciate the opportunity to be working with you and your team and everyone across the state of Ohio. Sepsis Alliance is a national organization, but we also are involved in many partnerships on state and local level, and it's really a philosophy of partnership that we enter into our fight against sepsis, and in terms of working with lots of advocacy organizations, state health associations, and the ability for any of our partners to co-brand materials with us, and that includes, I believe, 2 billboards, awareness billboards that are going to be going up in Columbus within the next week or so, which will be co-branded between Sepsis Alliance and the Ohio Hospital Association. So we're really excited about the partnership. Next slide, please. Back one, please. There we go. Happy Sepsis Awareness Month, everyone. It was in 2011 that Sepsis Alliance decided that it would be important to designate a month. It was actually 2009, but after 2 years of waiting for the federal government to take action on it, we decided to do it ourselves. So it's been very effective as a way to really focus attention and energy into creating a higher profile for the need to raise awareness on sepsis. So lots of opportunities to engage, including, and thank you to Governor Kasich and to the Ohio Hospital Association for, again, designating September as Sepsis Awareness Month in Ohio. And we have other states and major cities across the country who are doing the same. And it's really helpful just in raising the profile of a disease that really needs its profile raised. We have 5K walk runs and spike out sepsis volleyball tournaments happening all over the country. We have a sepsis superhero challenge that is going viral, very much like the Ice Bucket Challenge. And hopefully one day we'll reach that atmospheric level of engagement. We have toolkits for healthcare providers and volunteers so that they can go out and engage their coworkers and members of their community. And this year we launched a state and local government toolkit so that government health associations, again on state, county, and local level, can have materials like they do for Breast Cancer Awareness Month and other awareness months to share out with their constituents. So it's really about raising awareness. Next slide, please. And when I first got involved with Sepsis Alliance, I met Dr. Flatley, who had never heard of sepsis. He had been doing oral surgery for about 25 years, never heard of sepsis until his daughter developed an infection following routine surgery, oxymoron in many cases, and Aaron passed away of sepsis a week later following that surgery. So from that point on, we decided we needed to understand what the awareness issue was and the challenge was in the country. And when we started, only 19% of the country had heard the word sepsis. And in fact, when we got started, spell check would kick the word sepsis out if you typed it into your computer. Next slide, please. So here's where we've come. Just last week, we announced the results of our latest survey. We do one each year, and you can see here that the results are really dramatic. We've gone from 19% back in 2003, the year after Aaron passed away, and this year we are at 65%. So comparing to 2012, that's 60 million more American adults who are aware of the term sepsis, and more than 100 million adults who are aware of the term sepsis, as opposed to the number back in 2003. So awareness is great. It creates the opportunity for action and education. So next slide, please. But what we found is awareness is growing rapidly, but knowledge of the sepsis symptoms is still lagging quite dramatically. So we took a hard look at this and kind of studied what the stroke organizations had done to increase awareness so dramatically of stroke. And they stumbled for many years. They had this long list of symptoms, and it was a perfect list. It was a comprehensive list, but it was unusable. It was too many things for people to remember. So we were using SEP-SIS as our mnemonic, and it was too many things for people to remember. So we did a lot of work with our medical experts and our marketing team, and we came up with time, and it works so well because sepsis, it comes up again and again. This is a disease that's about time to treatment. We know that 87% of cases start in the community, and time to treatment is critical, with mortality increasing as much as 8% with every hour the treatment is delayed. So T is for temperature, higher or lower than normal. I is for signs of an infection. M is for mental decline, often the clincher. And E is for extremely ill, severe pain or discomfort. So easy to remember, easy to activate the national audience on sepsis. The key symptoms of sepsis, and we're hoping that we will be up in the awareness levels that stroke is, particularly given that sepsis is twice as common and twice as deadly as stroke. Next slide, please. So Angelica Hale is almost, she's a classic story for this webinar, because we're talking about pediatrics and we're talking about pediatric patients who present to a general hospital emergency room. That's Angelica's story. She was 4 years old. She developed the flu. 3 visits to the pediatrician yielded conclusion that it was some kind of a virus. She got much sicker over the weekend, and her parents, who you see here, took her to their local hospital. Fortunately, the local hospital realized that she was sicker than they could deal with, and they called for a helicopter to take her to Children's Hospital of Atlanta. So it's really a classic story for our webinar today. And young Angelica survived sepsis and ended up having kidney failure as a result of the septic shock and required a kidney transplant, which she got from her mom. And Angelica has signed on with Sepsis Alliance to be our national spokesperson for the It's About Time campaign. And we're so pleased to have her, because she's a great spokesperson for an undermarketed disease, and her family and the entire story is really just a classic educational opportunity. And we have a short video that you'll be hopefully seeing on your local television stations and cable networks very soon, a public service announcement we created with Angelica.
But the real miracle is that you even made this.
So I don't know if people could hear the audio, but if you go to our website, sepsis.org, we have this video in addition to a longer version of this video that tells more of her story. And we've also produced a radio public service announcement, the billboard you'll be seeing in Columbus soon, which features Angelica and TIME. And we've produced digital ads and print ads and all kinds of infographics and things like that on the campaign that we're happy to make available free of charge, and we're happy to co-brand with any institutions that are out there. So as is true with all of our materials, we're working with lots of state hospital associations across the country and large major health systems, offering our suite of materials so that they don't have to create things from scratch, that we can offer our existing library of materials on patient education and provider education and co-brand, so that there's a sense of local ownership, and you don't need to create these things from scratch. We can work together. So thank you very much for the time, and I appreciate all that you guys are doing out in Ohio to save many, many lives.
Tom, thank you so much for your ongoing support of our statewide efforts, and we are grateful for your collaboration and the collaboration of the entire Sepsis Alliance. So again, thanks for being with us today. For everyone on the line, please know that you will be given an opportunity to type in questions through the chat box feature throughout the presentation that is following, and then questions will be addressed at the end of the presentation. This presentation is being recorded and will be posted on our Sepsis webpage, which can be visited at ohiohospitals.org/sepsis and by clicking on the education link. And there you'll find all of the previously recorded sessions that do not contain member data. This program has been approved for 1.0 contact hours of continuing nursing education. You will be provided with a link to an electronic evaluation tool, and you will need to log on and complete the evaluation and request your certificate. We'll keep this link open and live for 2 weeks following today's date. Lastly, we encourage you to visit our website, which is a repository of our resources and education. For example, a recording and the slides from the highly requested August 15th webcast on coding and CDI issues related to sepsis can be found there as well. Now it is my pleasure to welcome our guest presenter today, Dr. Jason Clayton, who is a pediatric hospitalist in pediatric critical care medicine at University Hospitals in Cleveland, Ohio. He also serves as assistant professor of pediatrics at Case Western Reserve University School of Medicine, also in Cleveland, Ohio. Dr. Clayton completed his medical degree at University of North Carolina at Chapel Hill School of Medicine, completed residency at Tufts Medical Center, where he was chief resident. He completed a fellowship in pediatric critical care medicine at University Hospitals in Cleveland, and he also holds a doctoral degree, also from University of North Carolina at Chapel Hill. Jason, I'll turn it over to you now.
Great. Thank you, Jim. I also want to thank the Ohio Hospital Association for the invitation to come in to speak to you all today. So the title of my talk, in keeping with the topic of pediatric sepsis, is to see if we can update everyone on the current state of pediatric sepsis as we understand it right now. Next slide, please. So the goal of my talk is to, again, review the history of sepsis and specifically pediatric sepsis, including the various iterations of how we define sepsis in children. We'll then review the triage and initial management strategies as currently recommended by the Surviving Sepsis campaign. And then we'll finish by touching on current and future research topics. Next slide, please. So my first task is to try and describe the epidemiology of the syndrome of pediatric sepsis. And I say try because this is made incredibly difficult by the changing definitions of pediatric sepsis over the decades. The prevalence has been reported to be anywhere between 6 and 18%. And again, this really depends on the study decade, the definition of sepsis that was used in that particular study, as well as the study population. Mortality, which is what a lot of us concern ourselves with, again, in the early 1960s, mortality from sepsis in pediatric patients was described to be as high as 90 to 95%. However, in recent studies, mortality data is anywhere between 7 and 25%. Again, a lot of this, the variation in mortality data depends on the definition that was used at the time, as well as the age of the patient cohort and the region of the world that the study was performed in. So it's clear that we've made considerable progress in the identification and treatment of sepsis, but there's still much to be learned from the syndrome. Going along with sort of the varying differences in mortality, differing sites of infection, again, different ages of the population, and even the presence of multiple comorbid conditions can modify the disease process and the outcomes. Next slide. So a recent point prevalence study sought to better characterize pediatric sepsis. The Sepsis Prevalence Outcomes and Therapy Study, also known as the SPROUT study, was a multinational point prevalence study that was carried out between 2013 and 2014. It was performed in 128 PICUs across 26 countries. A uniform definition based on the 2005 International Pediatric Consensus Conference was used to define pediatric severe sepsis in this point prevalence study. We'll get into the details of the definition in a little bit, but briefly, it's something that most of us are familiar with, I believe. It consists of 2 out of the 4 SIRS criteria, presumed or confirmed infection and evidence of organ dysfunction. And like I said, we'll go into a little bit more detail in a little bit. The point prevalence in this study was found to be about 8.2%, in keeping with some of the prior studies of pediatric sepsis. And mortality was 25%. The mortality rates of 25% held across all the age groups that were studied, from infants to patients 18 years old and younger. There was no difference in mortality between developed versus resource-limited countries. Interestingly, the most common sites of infection were identified to include respiratory infections as well as bloodstream infections, and this is also consistent with previous data in pediatric sepsis. And probably not too surprising, 30% of the patients that were recruited in this study presented from an emergency department in the same hospital as the participating PICU. And another 30% of these patients presented from an emergency department at a different hospital from the presenting PICU. So it's clear that there's a large burden of triaging and the initial management of these pediatric patients performed by my emergency medicine colleagues. Next slide. So let's take a step back and kind of see how we've come to define pediatric sepsis, because I think this is really important. Ideally, a definition would be easy to derive and easy to employ in a clinical setting. Perhaps maybe a biomarker or a set of biomarkers in concert with some physiological data may be helpful. Unfortunately, there is no gold standard test or definition for sepsis, or even though investigators are trying their hardest to find one. So the first formal attempt at definition occurred during the 1992 American College of Chest Physicians and Society for Critical Care Medicine Consensus Conference. This was followed in 2001 by the second Consensus Conference. And then most recently in 2016, Sepsis 3 was published, which completely changed how we define sepsis, at least in adults. We'll get into more detail in a little bit. Pediatrics was mentioned briefly in the Sepsis 2 definitions. However, no clear parameters were outlined to define pediatric sepsis as a separate entity. Next slide, please. So here I just tucked in an additional line here. In 2005, the International Pediatric Sepsis Conference was convened to establish a set of criteria to define pediatric sepsis. The goal was to try to facilitate categorization and prognostication and to allow better enrollment in pediatric sepsis studies. An additional sort of goal was to try to align it with the adult definitions at the time. Next slide. So we'll talk a little bit more now about sort of the steps that lead up to where we're at right now with the clinical definitions. So up until 1992, there had been numerous studies examining various therapeutic strategies and looking at epidemiology and prognosis of sepsis with, to be quite frank, varying results and difficult to replicate data. This was thought largely to be due to the various definitions and terminology that were being used in these various studies related to sepsis. Sepsis could have meant anything from a simple infection and bacteremia all the way to septic shock and organ dysfunction. So the heterogeneity of this population made study recruitment and analysis of these studies very, very difficult. So this consensus conference actually championed the phrase, the systemic inflammatory response syndrome, or SIRS, and further defined sepsis as a systemic inflammatory response from infection. And this is what most of us understand sepsis to be to date. So SIRS, as they defined it, had 4 criteria. So either hyperthermia or hypothermia, tachycardia, and in this case, heart rate greater than 90, tachypnea with respiratory rates greater than 20, or evidence is hyperventilation with PCO2s less than 30, leukocytosis, leukopenia, or bandemia. And to be identified with SIRS criteria, one had to meet 2 of the 4 of these criteria to meet SIRS. Next slide, please. So they went on to further define sepsis in this case as meeting SIRS criteria plus having an infectious process. Severe sepsis, going along this spectrum, was defined as having sepsis plus evidence of organ dysfunction, hypotension, or having a hypoperfusion abnormality. Hypoperfusion in this case could be manifest as a lactic acidosis, oliguria, or altered mental status. Continuing along this spectrum or continuum of sepsis with septic shock, this is defined as a subset of severe sepsis that manifested as persistent hypotension despite adequate fluid resuscitation, or the presence of inotropic or vasopressor support to maintain normal blood pressures. The terms septicemia and sepsis syndrome were removed from the lexicon as they were seemed to have no association with sepsis rates and mortality outcomes. It's clear also that the SIRS criteria that were derived have no basis in pediatrics because the wide variation in heart rates and respiratory rates seen from the infant age all the way to adulthood, to teenage years rather. And I'll talk briefly more about this in a little bit as well. Next slide, please. So in the intervening years, many trials were published using the 1992 definition of sepsis. Again, outcomes were variable. Many were equivocal. Many were negative results. So there was still no magic bullet diagnostic test or therapeutic paradigm for sepsis. It became increasingly understood that the pathobiology of sepsis was much more complex than we had appreciated, that the disease process itself was heterogeneous, and that the SIRS criteria, while thought to initially be useful, was too nonspecific and overly sensitive, and did not adequately prognosticate outcomes. So it says a second consensus conference was convened about 10 years later to try and, quote, redefine sepsis. So while they recognized that SIRS criteria were overly nonspecific, they also sought to sort of broaden the definition of what systemic inflammation can be, and they introduced a list of possible signs and symptoms of systemic inflammation. Next slide. Next slide, please. So what should be popping up next here is a list of diagnostic criteria for sepsis. There we go. So this consensus criteria, because they thought that the SIRS criteria were too limiting, sort of expanded the concept of the outcomes of systemic inflammation. So they redefined sepsis as having a documented or suspected infection and some of the following. So I circled some on this slide. So instead of just being tachycardic or tachypnic, having fever or abnormal white count, they included essentially abnormalities from every organ system imaginable. So you can meet one, two, or multiple of these categories to be defined as a septic patient. Scanning through this list, you may notice that there are age-related cutoffs for example, heart rate. So tachycardia was defined as greater than 90, as was previously in the adults. But then they also included greater than 2 standard deviations above the normal value for age. And this was in an effort to include some of the pediatric population. So while the group wanted to sort of decrease the sensitivity of defining sepsis and to increase the specificity of defining sepsis, I think what they may have inadvertently done was increase the heterogeneity of the population that was being described, possibly making further study of sepsis in terms of therapeutics just a little bit more difficult to interpret. Next slide, please. So is there a pediatric consensus definition? And the short answer to that is yes, right now that there is. Next slide. So in 2005, the International Pediatric Sepsis Consensus Conference convened, consisting of a panel of 20 experts from 5 different countries. And their goal was to modify the adult definitions and modify them and validate them for use in children. The SIRS concept was modified to include age-specific variations. Next slide, please. So this is a little bit of a busy slide, but this was pulled from the 2005 Consensus Conference paper by Goldstein and colleagues. So SIRS, again, was defined as the presence of at least 2 of the following 4 criteria, similar to what we have in adults. But the exception here is that one of those criteria had to be an abnormal temperature, either hyperthermia or hypothermia, or had to be an abnormal leukocyte count. The goal of this was to sort of limit the number of pediatric patients that would present with and be categorized as SIRS. Because you can imagine every asthmatic or bronchiolitic that comes into your emergency room would be tachycardic and tachypnic and would qualify for SIRS criteria if it were not for the requirement of having abnormal temperature regulation or abnormal white count. So tachycardia, in this case, was defined as having a heart rate greater than 2 standard deviations above normal. This is always very intuitive or easy to gauge. However, there are some EMR tools that help identify abnormal heart rates. It would not be out of the realm of ordinary for a newborn to have a normal heart rate between 100 and 150. In some cases, even heart rates of 160 and 170 may be considered normal, but are starting to approach abnormal. In infants and toddlers, we're looking at heart rates between 80 and 120, 130. In preschool and school-age children, again, between 80 and 100, 120 would be considered normal. And then in the adolescents and teenagers, we're looking at heart rates closer to what we see in adults, between 60 and 100. One sort of additional caveat to this is that instead of just strict tachycardia, bradycardia was also included as part of the criteria, namely for children less than a year old. And this was defined as having a heart rate less than the 10th percentile for age. Again, not totally intuitive, but probably on the order, we're looking at abnormal bradycardia would be less than 60 in this age group. Tachypnea was also included, again, a respiratory rate greater than 2 standard deviations above normal. Again, there's a lot of variability in respiratory rate in children. With newborns, again, with normal breathing patterns, breathing 30 to 50 would be considered normal in most cases. In sort of the toddler and up to the school age population, it wouldn't be out of the realm of ordinary to see respiratory rates between 20 and 30. And then in sort of the adolescent teenage years, looking at respiratory rates less than 20 would be considered normal. And then the abnormal leukocyte count, so whether it's leukocytosis, leukopenia, or bandemia, were kept from the adult criteria and applied to the pediatric criteria. So sepsis was still defined as having the SIRS criteria, 2 of the 4 SIRS criteria, plus suspected or proven infection. Severe sepsis was defined as having sepsis plus either cardiovascular dysfunction, ARDS, or 2 or more other organ dysfunctions. And then septic shock was a subset, again, of severe sepsis that included sepsis plus cardiovascular organ dysfunction. Next slide. So they reported organ dysfunctions with age-related cutoffs. There have been organ dysfunction scores that have been developed. During this study, this is adapted from the Pediatric Logistic Organ Dysfunction Score. One difficulty with defining, with these definitions is actually defining what septic shock means for pediatrics. So unlike adults, hypotension is a relatively late finding in pediatrics. So hypotension in and of itself, while would suggest septic shock, is not the earliest indicator of shock. An alternative definition was put out that included tachycardia with signs of decreased perfusion, including poor pulses, mental status abnormalities, delayed cap refill, mottled or cool extremities, or decreased urine output. So those definitions of septic shock are included in the criteria for cardiovascular organ dysfunction. So you can be frankly hypotensive with or without vasopressors, or have 2 of the other categories of poor perfusion to be defined as septic shock. Next slide. So again, more research was done, and it had, from 2001 to the current iteration that was published in 2016, demonstrated that sepsis is not just an over-exaggerated inflammatory response as previously thought. There's new evidence now, at least in animal models, that sepsis also includes a lack of or an impaired compensatory and anti-inflammatory response syndrome, also known as CARS, just to throw another acronym out there for you. Sepsis is now thought to be a general immune dysregulation in response to infection. And this immune dysregulation that subsequently leads to organ dysfunction. So, and it was also, again, reiterated from the 2001 conference, even until now, that the SIRS criteria were neither sensitive nor specific in defining sepsis or in prognosticating outcomes. And it's clear that SIRS may be an appropriate host response to an infection in many situations. Sepsis is also, as a model, was no longer viewed as being a continuum of disease, from sepsis to severe sepsis to shock. So the committee, knowing this new information, sought to redefine sepsis, and they redefined it as life-threatening organ dysfunction caused by a dysregulated host response to infection. So again, keeping infection as the primary cause and organ dysfunction as the ultimate outcome of sepsis. A host of organ dysfunction scores were developed in the intervening years, and this committee chose to use the sequential organ failure assessment, or the SOFA score, to aid in the definition of sepsis. And this was mostly because of the ease of use and the validation of its use in both the emergency departments and ICUs. So now sepsis, as they defined it, required an acute change in the SOFA score of greater than or equal to 2, in addition to a presumed or confirmed infection. The septic shock in this case was now identified as a subset of sepsis, which in which underlying circulatory and cellular metabolic abnormalities increased mortality. Clinically, septic shock was defined as persisting hypotension, again, despite adequate fluid resuscitation, requiring vasopressors or inotropes to maintain a MAP greater than 65 and lactate greater than 2. So the new focus here now is on, in addition to the global physiologic abnormalities, the focus also on the cellular dysfunction, as we begin to more understand the complex pathobiology of sepsis. Next slide rather. So the SOFA score is something that you all are probably more familiar with than me. It outlines gradations of organ dysfunction for the major organ systems. It was never intended to be used as a tool for patient management. For example, it was never meant to show a treatment effect by looking at a decrease in the SOFA score. It was validated as a prognostic tool and a clinical categorization tool. Some components of the SOFA score are available quickly with routine vital signs and exams, such as the mean arterial pressure and the Glasgow Coma Scale, whereas other components require laboratory analysis and thus may not be immediately available to the clinician. So while the SOFA score is useful for categorizing the severity of sepsis, it doesn't readily help the clinician to immediately identify the, quote, septic patient. Next slide. So the consensus committee recognized this and derived a tool that they called the quick SOFA, or the Q-SOFA, that may be useful as a screening tool for sepsis. Scoring 2 out of the 3 components offered similar predictive mortality validity as the full SOFA score did inside the ICU. And further, like the Q-SOFA was validated outside of the ICU setting, so in emergency departments and in clinical non-emergency settings. The Q-SOFA requires only physical exam and no laboratory measures, and may provide a quick entry to further sepsis workup if positive. And you can see here the Q-SOFA criteria were just a respiratory rate greater than 22, altered mentation, given a GCS score less than 15, and a systolic blood pressure less than 100. Next slide. So the committee offered a workflow to identify the septic patient, at least the adult septic patient, and it starts with applying the Q-SOFA criteria to a patient with suspected infection. If positive, then one could assess for organ dysfunction with the laboratory criteria outlined in the full SOFA score. And assuming an otherwise healthy patient with an initial SOFA score of 0, if a patient had a SOFA score of 2 or more, they would be defined as having sepsis. And if after adequate fluid resuscitation, the patient required vasopressors or inotropes to maintain a MAP greater than 65 and had a lactate greater than 2, they would be identified as having septic shock. So as these are new definitions, there still needs to be a lot more work done to validate these criteria in other patient populations. Next slide, please. So where are we now with respect to updated pediatric definitions? It would make logical sense to try to adapt the Sepsis 3 criteria and adapt the SOFA score with pediatric cutoffs, just as they did with the SIRS criteria during the Sepsis 2 guidelines. And again, with the goal of sort of streamlining diagnosis of pediatric sepsis. Unfortunately, we don't have updated criteria just yet. However, next slide, please. A study published from the University of Chicago attempted to modify a pediatric version of the SOFA score and attempted to validate this new pediatric PSOFA using the Sepsis 3 guidelines and Sepsis 3 definitions of sepsis. Next slide. So briefly, this is a single center retrospective cohort study that was conducted from 2009 and to 2016. The pediatric SOFA score was developed by adapting the SOFA with pediatric specific cutoffs. There were over 8,000 patient encounters. And what they found was that the PSOFA correlated well with in-hospital mortality in patients. And when paired with Sepsis 3 criteria, which again is suspected infection plus an increase in the SOFA greater than 2, or in this case, an increase in the PSOFA greater than 2, 14% of patients met sepsis criteria with a mortality of 12.1%. Furthermore, about 4% of patients met criteria for septic shock with a 32% mortality. Again, this data is in keeping with some of the epidemiological literature, including from the point prevalence SPROUT study. Next slide. So this is the pediatric version of the SOFA score as this group defined it. Again, keeping similar criteria from the adult SOFA score, including platelet counts, bilirubin counts, as well as the pediatric version of the Glasgow-Coma scale. The difficulties with the respiratory definitions is that we don't use arterial blood gases as frequently as is used in adults. So this group included a SpO2 to FiO2 ratio, which has been validated in pediatric ARDS as their measure of organ dysfunction, respiratory pulmonary organ dysfunction. And they also included age-related cutoffs for mean arterial pressure and serum creatinine to define those respective organ dysfunctions. Next slide, I think. Next slide, please. There we go. All right. So obviously, this is a single center study. It's a retrospective study. So all the limitations inherent in such a study are present in this analysis. So it's clear that larger prospective studies are needed to validate these criteria in categorizing and prognosticating pediatric sepsis. In addition, no sepsis screening tool similar to the QSOFA in adults was offered in the study. So it remains to be seen whether or not an updated consensus conference definition would address these issues for pediatric patients. So as it stands right now, we are left to use the 2005 consensus criteria, namely that sepsis is the combination of suspected infection plus 2 or 2 out of 4 SIRS criteria, with 1 being temperature abnormality or white blood cell abnormality. So this is not a perfect definition by any stretch, as no previous sepsis definition has been. A follow-up to the sepsis prevalence outcomes and therapy study, or the SPROUT study, showed a pretty significant discordance between what physicians were diagnosing at the bedside and what the consensus criteria defined as severe sepsis. Next slide. So 43% of patients, only 43% of patients met criteria by both physician diagnosis and 2005 consensus criteria. So a lot of patients that were defined as sepsis in the consensus criteria were not being identified by physicians at the bedside. And conversely, physicians diagnosing patients with sepsis did not necessarily meet consensus criteria. In fact, only 2/3 of patients identified as severe sepsis by physician diagnosis met criteria by consensus definitions. So the significance of this is that should a trial attempt to enroll patients for an interventional study, for example, 1/3 of patients would be missed based on just physician diagnosis alone. So it's clear that there needs to be some sort of congruence and of definitions for sepsis, and hopefully new sepsis definitions will be available in the future that may offer better predictive validity in pediatrics. Next slide, please. So let's switch gears now and talk about treatment and management, because really ultimately, I think many of us understand what a quote septic patient looks like. The key is to, what do we do with them after we've identified them? The key here is early recognition and prompt institution of therapy, just as it's been presented from the RIVER study in sepsis, and then through multiple iterations of the surviving sepsis guidelines. This has been shown to be the cornerstone in severe sepsis management. So currently, like I mentioned, we utilize the SIRS criteria and our clinical intuition, frankly, to promptly identify the septic child. And once identified, we sort of prompt initiation of antibiotic therapy, fluid resuscitation is vitally important. One of the key tools that have been developed with the advent of electronic medical records has been triggers, EMR triggers to identify abnormal vital signs and abnormal laboratory values to help prompt the clinician to pursue further workup or to even start earlier treatment. Much of the management of pediatric sepsis has been extrapolated from adults. In fact, there are very few prospective pediatric studies available. So what is clear is that quality improvement initiatives and protocol-driven resuscitation bundles have been shown to decrease time to initiation of therapy and greatly improve outcomes in pediatric sepsis. Also clear is that delays in prompt recognition and delays in initiation of fluid resuscitation, antibiotics, and even vasopressor support have been shown to increase morbidity and mortality in pediatrics. Next slide. So the latest iteration of the Surviving Sepsis campaign that contains pediatric treatment decisions was published in 2012. There's been an update for adults published in 2016, but the pediatric update is still pending. Management centers around prompt recognition and aggressive resuscitation. As always, we prioritize the ABCs. The patient is protective of their airway and spontaneously breathing. At the very least, one can apply simple nasal cannula, a venturi mask, or even a non-rebreather. Supplemental oxygen may be able to provide additional oxygen carrying capacity, as well as possibly mitigate cellular hypoxia and tissue injury. We know that high flow nasal cannula and non-invasive ventilation in the form of CPAP or BiPAP can offload respiratory muscles and decrease worker breathing and decrease metabolic demand, and may be a useful adjunct for non-invasive respiratory support in septic patients. Ultimately, there's significant respiratory embarrassment or the patient is obtunded and unable to protect their airway, then intubation and mechanical ventilation is appropriate. Aggressive resuscitation begins with establishing quick and prompt IV access. If one is unable to obtain quick IV access, then intraosseous access is preferred. The goal for fluid resuscitation is the reestablishment of normal physiology, or as near normal physiology as one can obtain. Remember, hypotension is a late finding in pediatric sepsis, so if present, needs to be treated promptly and aggressively. However, the presence of a normal blood pressure does not necessarily mean that the patient is not in shock or does not require fluid resuscitation, as I mentioned earlier. Other markers to target include a normal capillary refill, normal perfusion, normal pulses, establishment of urine output, and a return to or normalizing mental status. Shock is defined and treated as per the PALS algorithm, which I'll show, I think, in the next slide. Yes. So the key point of this slide, and this is another busy slide, and this is pulled from the last iteration of the PALS Pediatric Advanced Life Support Guidelines. But the key point here is that the initial fluid resuscitation should be fast. The suggested algorithm is to give 20 mLs per kilo of either crystalloid or colloid over 5 minutes. So this is like a push-pull IV fluid bolus. And to repeat this as necessary until the establishment of the previously mentioned parameters, or in a negative sense, if hepatomegaly or pulmonary rales develop. So the goal is that by 15 minutes, you will have given at least 60 mLs per kilo of fluid. if needed, or at this point have decided or even started inotropes if required. For fluid refractory shock, the algorithm progresses to the use of dopamine for cold shock or norepinephrine for warm shock. And for catecholamine-resistant shock, the administration of hydrocortisone is recommended. So again, in an ideal scenario, all of this should happen or be happening within 1 hour while still in the emergency department. Goal-directed therapy in pediatrics is to target perfusion, pulses, urine output, and mental status. The use of SVO2s or CVP monitoring is often done in the pediatric ICU. These guidelines, like I mentioned, were published in 2012, and there's been many published research studies in resuscitation and sepsis. So there are some caveats to these guidelines, which I'll discuss next. Needless to say, we need an updated pediatric surviving sepsis guideline. Next slide. So again, in addition to adequate and aggressive fluid resuscitation, a keystone in treatment is the prompt initiation of broad-spectrum antibiotics, ideally within 1 hour of after appropriate cultures are drawn. Delays in antibiotic administration have been associated with poor outcomes, so they should not be delayed if cultures are difficult to obtain. The 2012 guidelines also recommend colloid or crystalloid for fluid resuscitation. There's been several studies in adults, namely the SAFE trial, Crystal trial, and the Albios trial, that showed no differences in mortality between the two fluid choices. There are no prospective data in pediatrics. However, the Sprout study showed an association with increased mortality risk with the use of albumin. So further study obviously is needed, but I will still maintain that the current recommendations are to use crystalloid or colloid. Next slide. The choice of inotropes and vasopressors has also evolved since the 2012 guidelines. Recent randomized controlled trials in pediatric sepsis have demonstrated increased mortality, longer duration of shock, and less resolution of shock in patients that receive dopamine compared to epinephrine. Next slide. This is a Kaplan-Meier curve for dopamine versus epinephrine in one of these studies, showing a clear survival advantage for epinephrine and septic shock. Next slide. So while some institutions continue to use dopamine, I think most are moving away and using epinephrine as their first line for cold shock. Norepinephrine remains the first line for warm shock. In adults, I believe that vasopressin has shown some promise as an alternative for norepinephrine. In pediatrics, it would be a reasonable choice. However, there are no data to suggest superiority of vasopressin over norepinephrine. In fact, a recent systematic review and meta-analysis shows no mortality benefit of using vasopressin versus norepinephrine. So I would say that norepinephrine is probably still the first line choice for warm shock presenting in pediatric sepsis. Next slide, please. Adjunctive therapies such as hydrocortisone are currently recommended for catecholamine-resistant shock, or even when known or relative adrenal insufficiency exists. A common practice seen in many pediatric emergency rooms is to send a random cortisol level during the initial workup. And if the level is low or even low normal, most practitioners, in fact, up to 90% of pediatric intensivists, when surveyed, would administer steroids in this situation. So because of this, randomized controlled trials examining the efficacy of steroids in septic shock have been difficult to design and difficult to enroll patients. In addition, the Sprout study, again, this point prevalence study, showed a risk of mortality with steroid use in pediatric patients with sepsis. Again, no randomized or prospective studies have looked at hydrocortisone use or steroid use in pediatric sepsis. Next slide. So where does this leave us? So again, to reiterate, sepsis is a heterogeneous syndrome that lacks a gold standard. Given our current definitions, stratification and good study design has been difficult to say the least. And many results of promising therapies have been equivocal or negative. We now know from animal models that sepsis is not just a pro-inflammatory state, that it's a complex interaction between an overactive inflammatory system and an impaired compensatory anti-inflammatory system, and that there is some evidence that this also presents as an acquired immunodeficiency, leading to immunoparalysis. Next slide. The complex and complexity of the inflammatory paradigm is outlined in this diagram. Each aspect of the inflammatory and anti-inflammatory system can impact and influence the other. coupled with a diverse microbial pathogen milieu and other host environmental risk factors, make sepsis much more complicated than once thought. Next slide. There are promising new areas of research for sepsis, both in pediatrics and in adults, and we're beginning to identify, quote, sepsis phenotypes using analysis of the microbiome, transcriptome, proteome, metabolome, genome, and every other omic technology that's out there. Next slide. So this is just one example of the differences on a transcriptional level of patients identified as having severe sepsis. The top panel represents 3 different patients with one particular pattern of gene expression, whereas the bottom panel represents 3 other patients with a different transcription panel. All 6 patients were identified as having severe sepsis per the Sepsis 2 guidelines. So you can see that different expression phenotypes may lead to defining different sepsis phenotypes that may respond differently to therapeutic regimens, or even have different outcomes for treatment or different presenting symptoms. Next slide. These new sepsis phenotypes have led to promising new targets for therapy, which are currently in development for larger trials. One study identified a host of enzymes that require zinc as a cofactor, and there's currently a phase 1 trial in development to study the role of zinc supplementation in patients with severe sepsis. These omic technologies are also identifying potential biomarkers, which may be used alone or in combination with other markers to better categorize and identify the septic patients. For example, in animal models of sepsis, cytokines such as IL-27 and proteases such as MMP8 have identified as being highly upregulated in septic animals. Inhibition of MMP8 in mice confers a survival advantage for sepsis. And in IL-27 has been studied as a potential biomarker in pediatric sepsis and has been shown to be superior to procalcitonin alone in predicting severe sepsis and bacteremia. However, its use in adults has not been shown to have the same results, again pointing to the heterogeneity and differences in adult and pediatric sepsis. Next slide. So what are we waiting for in pediatric sepsis? We're still awaiting the publication of updated consensus definitions for pediatric sepsis. Perhaps a modified pediatric version of the SOFA score will be codified and used for future studies. An analogous screening tool similar to the QSOFA would be welcome as a quick entry point in identifying pediatric patients with sepsis. Also, given the research into specific therapies since the 2012 Surviving Sepsis Guidelines, an updated treatment guideline is also pending. Presumably would incorporate the new data on resuscitation fluid choice and vasopressor choice and use of adjunctive therapy such as steroids. Next slide. So what's the bottom line here? So until new recommendations emerge, the current recommendation is to continue to use the 2005 pediatric consensus definitions, namely 2 of the 4 search criteria, with 1 being temperature abnormality or white blood cell abnormality, plus suspected infection, and organ dysfunction. Likewise, treatment decisions should be guided by the 2012 Surviving Sepsis Guidelines for the management of pediatric sepsis. Again, the key to treatment here bear being repeated: prompt recognition, early initiation of treatment, early administration of antibiotics, aggressive fluid resuscitation, and early use of vasopressors if needed. It's clear that pediatric sepsis is important with respect to increasing incidence and high mortality among pediatric diseases. And while the academic world grapples with the definition of sepsis, I would posit that currently available definitions and your clinical intuition are probably most helpful in identifying and treating the septic patient. And again, as always, early recognition and aggressive treatment are key. So with that, I appreciate your time and patience, and thank you all again for the invitation. I'm happy to answer any questions or to the best of my ability and hopefully to the best of your satisfaction. Thank you.
Thank you, Dr. Clayton. I did want to address a couple of questions that came through our chat line. First of all, just to clarify, handouts from this webinar today, copies of the slides and the recording will be posted to our website at ohiohospitals.org/sepsis. Again, the recording as well as the printable slides that Dr. Clayton has offered today. Some questions that have come in that I'll put out to you are, the first one is, can you clarify your statement on, or your comment on the use of QSOFA?
So QSOFA, again, was identified during the Sepsis 3 consensus conference, and it was used, or the goal of it was to be used for quick screening for sepsis in adults. So the respiratory rate blood pressure, and mental status. Two of the three of those criteria should prompt the clinician to further pursue whether or not the patient has organ dysfunction. The QSOFA has not, as of this point, been derived or validated in pediatrics. So we are still currently using the search criteria.
Thank you. The next question is the fluid resuscitation for hypotension that you showed specific to sepsis? Yes.
So, and probably more so septic shock. So that algorithm from the PALS that I showed was the algorithm for septic shock. So if you have a pediatric patient with presumed septic shock, then that aggressive fluid resuscitation applies to them. So 20 per kilo over 5 minutes, so rapid fluid boluses. For a patient, again, what's difficult is that, hypotension, again, is a late finding. So I would argue that a patient with tachycardia that also you are worried about sepsis is probably in shock, and I would treat them aggressively as well.
Thank you. Our last question states, our hospital has tried to provide sepsis community awareness efforts. What message about sepsis in children is most important to send to our community?
That is actually a really good question. From my standpoint as an intensivist, I would argue that being overly sensitive at recognizing or at defining pediatric sepsis is important. The risk of missing a diagnosis of pediatric sepsis can be catastrophic. So again, until new definitions are put forth, I think the search criteria are relevant. I think your clinical, sort of your gut intuition that an unwell patient that, quote, looks septic may in fact be septic and would sort of necessitate or obviate further workup and evaluation. It's really hard, I think, to sort of to find that balance, because I know in the community, no one wants to miss a septic patient. So that, again, that's why I would argue, from my standpoint as an intensivist, that over-recognizing a septic patient would be better than, not recognizing or under-recognizing one. Does that answer your question?
Yes, thank you very much. Thank you, Dr. Clayton, for your very extensive overview today of pediatric sepsis and the considerations that we have. And I would like to thank all of our listeners today for joining us. As a reminder, our next call will be held on Wednesday, October 17th at 11:30 a.m. Eastern Standard Time, when Michael Ewell, president of Premier Health Atrium Medical Center, located in Middletown, Ohio, will address the topic of executive sponsorship of sepsis initiatives. We certainly hope that you'll join us then. Again, thank you to Dr. Clayton and also to our other guests. And this concludes today's call. Have a great day.